So our next speaker is Mike Smith, who's a Defence Senior Lecturer in General Practice and Primary Care. And without further ado, he's going to be doing a talk on prolonged care in the low-resource environments, which I'm very much looking forward to and which will feed into the talks that we've just had from before. So without further ado, Mike Smith. Thank you very much.
Thanks very much for inviting me down to have to give you this presentation. I was worried upstairs. I've just gone for a coffee and realised that half the people whose work I'm going to present as my own are upstairs and coming to join us. So that's blown my first base, really. Good start. So I'll start with a disclaimer, like all GPs would. This is just a little reminder for me. Well, the first thing to say is that most of this is opinion-based research work that I'm doing within the academic department, and in some way does reflect defence, but also there's some ideas and things I need to present to defence in terms of my research. The picture reminds me really that no matter how well you plan, never underestimate your population's at risk ability to injure themselves in one way or another, and they'll always do it in the place that's least convenient for yourself. So I thought I'd give you a quick taster. Normally I chat for an hour or so, but I've been given 30 or so minutes. So we're just going to dance through my perspective really on prolonged care, why I feel there's an imperative to innovate in this field. Hopefully share with you some best practice, some ideas. I don't have solutions, but I do have a lot of ideas. And just give you a steer on some of my current research focus and areas that excite me and I hope will interest you as well over the next few minutes. So I am a military GP. That's not an excuse or an apology. My day-to-day job, as you can see, is the usual cough, colds and chlamydia, and if I feel like spicing it up, I might throw in some ibuprofen and some Tubigrip. The reason I put that up or make that introduction is that when people say, what do you specialise in? Because everyone has to have a specialty these days. And I think my specialty is just being general. And being a generalist comes with a few problems, because my employer likes to send me on very aggressive camping holidays. And whilst I'm in the academic department for the past 15 years, I've probably spent most of my time supporting frontline infantry in one shape or form. So I have to transition relatively quickly into dealing with other types of problems, the catastrophic hemorrhages, the coagulopathy, and the Casevac problems, particularly of delayed Casevac. That's not to mention that my talk doesn't cover the bulk of my work, which is disease non-battle injury. So we're going to talk about prolonged care in a moment, and the challenges I have as a GP, as a non-expert who's out there doing that. And we can discuss in coffee later why it's GPs forward and not somebody else, but that's just the way the military does business. So perhaps if I give you a little bit of a historical context as to why I feel it's important to innovate in prolonged care. You'll notice I call it prolonged care and John called it prolonged field care. That's from pressure from the Royal Navy, because they don't do work in fields, they do it aboard ship. So I've removed the field just to be politically expedient. But if I start you at the 12 o'clock position, in terms of recent conflicts like Afghanistan, we really did evolve lots and lots of different medical procedures, which I'm very pleased to see are filtering into civilian practice. At the top, of course, is the preparing our troops for combat, and everything that we did prior to getting them ready, the training that got them or took them to a place where they could deliver quite excellent medicine. If we move to the 1 o'clock position, John talked about the tactical combat casualty care. The Brits have a different name for it, but it's basically the initial actions on finding somebody severely injured. And I'll show you some graphic evidence later that this was a fundamental change in the ability to save people on the battlefield. What quickly happened in Afghanistan, I'm sure you're aware, is a big shiny bird came out of the sky and a consultant-led resuscitation team quickly swept the casualties away to definitive care. And on board, of course, the helicopter was all the latest advancements in terms of transfusion protocols or transfusions, consultant-led teams, all the things that we now see in the hospital and the ambulance services. Of course, our casualties were evacuated to arguably one of the best trauma centres in the world at the time, and that was Camp Bastion, and there was, of course, Kandahar, where nothing short of small miracles happened, and I was very privileged enough to do 3 or 4 months there myself and see truly unsurvivable injuries almost walk away. And then, of course, once that magic was done, they went back to the QE hospital, where their surgery was completed, and then, of course, to the world-leading Headley Court in terms of rehabilitation. The one phase that was missing out of that Afghanistan didn't provide, was the prolonged care piece. because on average, the helicopter came and took people away in about 54 minutes, I think is the average. Chris will correct me. Which is amazing. You wouldn't get that in the centre of Birmingham if you were shot, to be perfectly honest. And so the joke used to go around, it's probably better to be shot in Afghanistan than anywhere else in Britain. But that, again, poses a problem. So for 15 years, we had no real pressure to innovate or evolve prolonged care. As a Role 1 doctor, you're just overflown often a lot of the time. Although there was work going on in the background, as I'll tell you, in terms of improving our ability to do prolonged care. The future world is very different. We are now likely to go to places where we can't enjoy the luxury of having rapid helicopter evacuation. And so prolonged evacuation chains and poor medical resupply is probably the norm for people like me, not just GPs, but also our medics, our nurses and our paramedics who'll be working forward in remote locations. And I think this is where I can draw a parallel for many of you who work in equally remote environments during your expedition-type medicine and work in hostile environments. It doesn't have to be someone shooting at you. It can just be the climate or the environment that you're working in. But they all produce adverse situations in which we're trying to deliver best practice medicine. And so this is really where the pressure to innovate and polish up our prolonged care has really come from. It was interesting, I heard John speak in the States. He talked about our ability to adapt Afghanistan to what we wanted. We're now in a new world where we have to adapt to the world that we work in, and that's quite uncomfortable for me as a military physician because we've had it on a plate. So, certainly in British military, there is some confusion about what we mean by prolonged care. A lot of false or fake news about it. So I'll just give you my slant on it, and everyone can have their own definition. It really doesn't matter. But what we're trying to do in terms of prolonged care, as you can read there, is just to maintain someone's physiology so I can get them back to a clever doctor who can complete the definitive care that's required. So it's about preventing deterioration. I'm not an expert in critical care. I just want to learn to do the simple things and the simple interventions that save lives. You'll laugh. This used to be the comfort zone. 10, 1, 2, 10 minutes to a doctor, 1 minute to 1 hour to a doctor, and then 2 hours to definitive care. Wow, you'd say, that's pretty amazing. And that's what we worked to in Afghan. And in fact, it went to the 60-minute rule for the US. Nowhere, no serving person could not be within 60 minutes of being swept back to Bastion. That's a massive comfort blanket to take away when we're now talking about we could perhaps replace those to 10 hours, 1 day, 2 days. So it's a really, really uncomfortable place to find myself in, and many of my colleagues feel the same. Some of you have seen a curve like this. They're published in many papers. I don't want to really get into the weeds. I just wanted to point out the inflection point, the point there where actually training our medics forward, training the personnel who aren't even medics to do basic hemorrhage control and airway manoeuvres probably, and the evidence supports this, saved most lives. And you can see the way the curve lifts. But the one thing that was missing from the data, it doesn't matter how many times you retrospectively analyse the data, of which we have oodles of data, lots and lots. We haven't got any way of extrapolating data about long-term prolonged outcome because we didn't have much. So I had to dig deep back into the past. You have to look at World War I, World War II, Vietnam, to understand where people died after that first hour. So the first hour is great. We've got all the algorithms in the world. Matt spoke beautifully about everything a pre-hospital care doctor needs to do. But there is that moment, particularly as a GP, when you look up and you think, right, I've done the algorithms, now what do I do? What do I need to do to change the outcome of this person when I can't deliver them to definitive care when I want to? And if you dig through the evidence would seem to point to the things that will kill our patients most is shock and end organ failure and sepsis. And this is borne out as well by some of the work I've looked at from the International Red Cross and their wound care surgery manual. The two things they really focus on and that really bother them is the development of sepsis in an already immune-compromised patient and also the shock, the end organ failure. How are you going to resuscitate that patient? So in the British military at the moment, and it's shared across the pond with our US colleagues, we use an acronym along the lines of HITMAN. For those of you who are not familiar with it, the head to toe is really what we call the secondary survey. It's the time when you've got some quiet time, if that's such a thing, to work from top to tail to identify all the subtle injuries, areas of wounds that you've missed while you're having the big flap about the limb that's missing or the serious chest wound. And it will be important, as I'll allude to a little bit later. Hydration, always a problem if you are a medic who hasn't got IV access and your patient is unconscious. I'll touch on that. And just the general hygiene issues of working in dirty environments. We have to touch on infection. They have to think about the tubes, about what's going in, managing the cleanliness around those tubes. Challenges around medication. I think the one thing I didn't mention was that we've got a simple rule. If you can't carry it, you haven't got it. And there's a grounding rule, 25 to 30 kilograms, I would suggest, is the absolute maximum load a doctor could carry on the ground. So you really have to think about, what am I going to pack that's going to make a difference? That was easy in Afghan in some respects, because within an hour, somebody like Chris will fly forward and collect your casualty. But if you're there 2 or 3 days, you've got to be a little bit more savvy about what goes in your medical burden. You need to think about analgesia as well. Long-term management of analgesia. It's a real challenge in the forward environments, I'm sure many of you know. And then, of course, get the notes right, the nutrition. And I've highlighted nursing care because the one thing that's fallen out of most of my research is the importance of nursing care. Before I move on to that, I'll just talk about some of the key components I think are worth thought. And unfortunately, on a 30-minute presentation, I can't really address all of them, so I'm just going to cherry-pick a few, as I say, as a taster. But really, we need to think about hydration, what hydration we take, what we use, the protocols we use, and the end states we're trying to achieve by using hydration. Again, some of my medics can't pass catheters, so then how do you measure how well you're doing your fluid balance? These little challenges that seem perhaps trivial to us, but a real challenge to the medics. Nutrition's a hot topic, when to feed, when not to feed. If you ask 10 critical care consultants, you'll get 11 answers about whether to feed or not to feed. And I'm not going to go into that one. I've took a big sidestep on this one. Nursing care, probably the fundamentally most important thing. Bad nursing care kills patients. And as a GP, I look for simple things that make a difference, and I'll touch on that one. Wound care, again, a really important area. Lots of doctrine about how to clean wounds. 6 to 10 litres of normal saline to irrigate a wound. Well, that's my Medbergen full already, and that's just to wash the wound out. What about the hydration? I am delicately going to touch on the world of blood resuscitation, mindful there's a room full of experts who'll shoot me down, but I'm just going to dabble my toe in that one and talk to you about some of the ideas we're thinking about. And of course, there's the medications, there's the documentation, fundamentally important and terribly done on the ground. I'll say hands up, it's very difficult to keep contemporaneous notes in some of the miserable places I've worked. And of course, if you haven't kept contemporaneous notes, it's also extremely difficult then to spot the trend analysis of whether your patient's big sick, little sick, getting better or whatever. So, patient care. I think the key fundamental point is I'm not a nurse. And like all self-respecting medical students, the second a patient wanted to do a number 1 or a number 2, I pressed the nurse call button and I was out of there, looking for the more rarest medical conditions I could find that I'd never see again in my career. So I focus a lot on this, and the evidence would support that teaching people, and we do this on a 3-day course, the benefits of thoughtful nursing care based on a paradigm makes a difference. Understanding that you have to support their activities of daily living rather than getting that surprise at the end of the bed a couple of hours after you've started their care. Positioning your patient. So what we don't want to develop over the course of 2 or 3 days are pressure areas, are hypostatic pneumonias, the head-injured patient, how do you position them? So it's all sounds simple, but it's quite important, things that wouldn't be considered the norm perhaps for some of our medics. Psychological support, never underestimate that. Good psychological support will reduce your need for pain management. It will reduce your need for all sorts of drugs if you're convincing the patient that they're going in a good place. And of course, unfortunately, we don't live in Hollywood. And so preparing our medical personnel for the concept of palliative care and of resource management as well. It's a limited amount of resource you carry, and with the best will in the world, you might have to restrict some of that if it's an inevitable outcome. So again, touch on another key area which I think is fundamental, and that is the prevention of sepsis, really, and wound care. So we've been working a lot, and I've been looking at a lot of the US work on this. Military wounds are heavily contaminated. That's not to say wounds out on expeditions aren't. But some of the work is pointing to the fact that these colonise within about 10 minutes of the injury. And that's quite fundamental, because you used to think you could leave these wounds for a while and get round to it eventually. But the evidence is really pointing towards get in there and get these wounds cleaned as quickly as possible to stop the overwhelming infection and sepsis developing. Now, of course, if you're in hospital medicine, you've got lots of clever things like sepsis 6 and SOFA and Muse and News and loads of other algorithms I've found in the critical care world. And the challenge is a lot of those are driven by hospital-based blood results or other types of tests, none of which we have in the pre-hospital world. So there is some work I'm doing with colleagues to develop sensitive scoring systems which will just inform or provide a nudge for the medical personnel in terms of where that person is in terms of their bacterial or infection load. Again, fundamentally, if you're trying to deliver as well a patient as possible to my secondary care colleagues. Here we go. So resuscitation. So most of you, or I hope many of you know that the British military paradigm for many years has been hypotensive resuscitation. That careful balance between not wanting to blow clots. So I guess I'm talking about the non-compressible hemorrhages, but it was also probably the norm for the compressibles. So we didn't want to blow the clot, but equally we understood that perfusion and flow were really good things, and we didn't want end organ failure. So there is a balance to be struck. And at the moment, we run hypotensive resuscitation at endpoints at around about 90 millimetres of mercury. The current evidence is pushing us, and you'd be probably surprised to know there's not that much evidence to support using blood, which sounds a bit odd, but that's the honest truth. It sounds intuitive we should use blood. You've lost it on the floor, so top them up. And so certainly we're definitely moving towards using blood as a resuscitation product, and probably moving towards an endpoint, probably up in the hundreds and 110 millimetres of mercury. Correct me if I'm wrong, Chris, but we're working towards that as a comfort zone. Probably too early yet to see that in algorithms. Warm blood is great. Freeze-dried plasma or fresh frozen plasma is probably of choice. We pioneered this work back in 2009, so we've run probably 500 missions now where the GP, the doctor on the ground, was taking blood forward with plasma as well, to be used as a resuscitation product for those seriously ill on remote jobs where evacuations were well outside the hour that was considered norm. We throw in TXA in the mix there, and I think my colleague Chris Wright will talk about that a bit later. And the emergency donor panels as well is work that we're looking at, because, as I've already said, if you can't carry it, you haven't got it. But actually we could have a walking donor panel with us, and my colleagues across the pond, the Ranger battalions, have done some outstanding work in showing that EDPs can work, and they're certainly on the go in Syria, and they've saved many hundreds of lives by using local EDPs. So I'm not going to touch any more on resuscitation than say blood is good if you've got it, but the best resuscitation fluid is what's in your Bergen at the time. So no one-size-fits-all. There's never going to be one simple solution to our problems. If you ever want to know what a consultant anaesthetist does for the 99% of the time that there's no panic in theatre, then this is what it is. It becomes a PowerPoint ninja. So I have to thank Professor Tom Woolley for this. This is a shared vision, really, of probably what will happen in terms of us going abroad. It will be a function, really, of the ability of the individual, so their clinical competency. It will probably be a function of where we're going, and it will be a function of the logistics support that supports that particular operation. And we'll just cherry-pick based on the threat risk, whether it's a highly kinetic operation, i.e. people are going to get shot, or whether it's a humanitarian-type job. But the idea is we'll put a bespoke resuscitation package together, and then you'll go out with the best fit for that job based on where you're going to go. So I'm mindful of time, so I'm just going to skip on and chat a little bit about where I've taken prolonged care. So you saw the Hitman algorithm, which is a very nice tick box list, and pre-hospital care doctors like tick boxes. But actually the one thing that falls out from the evidence and the research is we need a process of care, certainly for those of us who are non-experts in critical care. So if I can just allude to in the top sort of flow diagram here, the phase 1 of the immediate care of the casualty, the immediate stabilisation of the casualty, sorting out the monitoring and making sure your casualty is stable in what we call the semi-high threat environment. The next thing really to do is to move your patient to an area of safety so you can start doing what we call the head-to-toe secondary survey. I know I'm preaching to the converted in the room. But what that does is it produces a problem list. And in that problem list, you're supposed to identify and prioritise what needs to be done. So in this lower loop, with Hitman as the focus, we're looking at a 1 hour, 2 hour cycle of care, just as a nudge, a reminder for our medics what they should be doing within that cycle, because we're not nurses and we're not critical care practitioners. So we need to do some monitoring, we need to capture some trends, we need to put some analgesia and make sure our analgesia management's up to speed, and so with other medications. We need to get amongst the wound and start irrigating these wounds And the general rule of thumb is if you can drink it, you can wash the wound with it. We need to be on top of our nursing care, our positioning, our activities of daily living, our psychological support. We need to do better documentation that's seen there. That's one of mine. Okay, we need to, from that documentation, trend and analyse what's going on. And we actually need to have a little bit of human factors in there as well, as Matt talked about. If you're one doctor, one medic, and 72 hours before somebody's coming to save you, you've got to factor in how you're going to deliver high-quality care to somebody over that period of time. And more importantly, you need to leave the patient alone to recover as well, because constantly being prodded by a medic wanting to do good but not quite sure what to do is quite upsetting for the patient. So it's a simple cycle of care that we run within our workshops to help develop that sense of the prolonged care that's required. So in a nutshell, and I'll summarise very quickly, we've got some clinical requirements and we've got some technical requirements. I've flipped through some of the key technical areas that I'm hoping to develop in terms of algorithms with support from the rest of my research colleagues within the academic department. I've got a big wish list of IT things I'd really like to do. And one of the things I've been very keen on is trying to prove the concept of remote physiological capture and telemedicine, so we can send data back to clever doctors and they can give me some advice about what to do when I'm unsure. I'm also very keen that we have intelligent support tools. We're in that era now while most medics carry a mobile phone or a smartphone or a pad. And so we're in that era where we can build in intelligent support tools. So there's a lot of emerging technology. I've been tracking this probably for about 8-9 years now, but we're certainly at a tipping point. So those sports you can see, or sports they're called jumping from space a sport, but it will be one day. All of those have got some sort of monitoring technology, as most of you do in the room. And I think we're at that time now where, as a doctor on the ground, a medic, paramedic, we need a bit of that technology to help us out. So there's wearables, stick them on your chest, quite clunky. There's stuff that goes on your head, do EEGs, all sorts of stress analysis of the head. We've got implantables, small glucometer devices that will read off basic glucose measurements. We've got hearables. You can pop them in your ear and they'll read off your tympanic membrane, what your O2 sats are, what your heart rate is. And all of those can be fed via Bluetooth to an array of different devices that you can interpret. And of course, you can build into that any number of guidelines that you want into that device to help our remote medic. So I was fortunate, as it always happened, you're in a bar having a drink with somebody, to come across one of 6 very remarkable women who are at this very moment walking across Antarctica. So after a few more drinks, I managed to convince them that they'd want to wear some wearable technology, or maybe even have some implantable technologies. Would they be my guinea pigs? I can't really give it too much detail, I'd love to, but this is part of a wider program called, for the Army in particular, Women in Ground Close Combat. So the bottom line is we don't know much about women's ability to cope in extreme physiological environments and doing endurance activity like this. So it was an absolutely ideal opportunity to wire the ladies up and get some data. And it proves my proof of concept as well, which is I wanted to do some remote physiological monitoring so that it was I could see their physiological state on a laptop on my desk. It sounds ambitious, but actually the technology is out there. It just took a little bit of work to pull it together. So all that big stuff on the left-hand side, the kind of clunky stuff we carry around, I found a very clever team to build that device there. And as I'll tell you in a moment, it's got about 7 or 8 different modalities of physiological measurement, and it's about the end of my fingertip. Okay, it's about 3 millimeters thick. It hasn't got the hermetic coating on top, which makes it slightly bigger, but it's certainly in the implantable world, very implantable. The idea is, or was, to implant this in the biceps of the ladies, in the same place you put an implant contraceptive device. Time was against us, as was medical ethics, and unfortunately, I didn't get the implantable sensor in. But don't worry, watch this space. What we did do was get a wearable. And when I joined the Army 22 years ago, I never thought I'd be a world expert in sports bras for women. But I am. And more dodgily is I had to make some very unusual phone calls to 6 women and ask them to send me their bras, which is a career-limiting choice in the military, I can assure you. But some very, very clever people, and I claim none of this work, except I gave them the ideas about what we wanted, and some close collaboration with the team at the Hamlin Centre, they've produced a flexible PCB circuit board. It's about 4 centimetres long. It's about 1 millimetre, maybe half a millimetre thick. It's completely flexible, and it will produce all those biometrics, which I think is pretty clever. The good news is we got data back from Chile, and this morning I've had my 3rd wave of physiological data back from Antarctica whilst the girls are walking across the ice cap. How does it work? Using near-field technology. So each of the girls has a smartphone. They walk all day. The device has got a small memory device on it. Well, actually, it's enough to capture the whole expedition. In the evenings, they capture sound bite of the data onto their phone, and then using Wi-Fi technology to an Iridium Go commercially off-the-shelf satellite, we stream the data back to a desktop. It could be done real-time. It's not done real-time because, for many of you in the audience will know, we don't know much about extreme physiological response, so we don't want to be put in the position of making difficult physiological decisions with data we just can't interpret. So this is called black box. So all the data is going back to the Institute, and we'll analyse it once the ladies have successfully completed their mission. I've got 1 minute left. So that was my dream, really, is to do some remote telemedicine where we can read physiology, we can send it back to experts, and we can have devices which give us an expert opinion about what we should be doing. And I'll leave it at that. Thank you very much for your interest.